welcome to the first session today, this live cases session, this mixed session with AT-AF cases and VT cases, 2+2. And we will try to connect to Homolka Hospital, which the first case is scheduled there, and it will be PVI with new compressible mesh basket catheter.
Okay, good morning from Homolka. Allow me to introduce first case PVI with FARAVIEW system and left atrial appendage occlusion with Watchman. We have a 79-year-old lady. It's a persistent AFib. It's very symptomatic. She showed up always or many times with the compensation of heart failure, preserved ejection fraction, and she had recurrences despite antiarrhythmics. She was scheduled on May 2025 for PVI, but the procedure was unsuccessful because of anatomy. We found out on CAT scan, and I'm going to show the duplication of inferior vena cava that merges into azygos vein and it flows into superior vena cava. And hepatic veins flow directly into right atrium. So those two vein systems are separated. We have bleeding complication October 2025. She has severe anemia due to gastritis. And a couple of days ago, we admitted her again for acute compensated heart failure, again with atrial fibrillation, tachycardia, bradycardia syndrome. And because the bradycardic episodes were significant, we had to implant pacemaker. She's got diabetes, hypertension, peripheral artery disease, and she's obese. So we have a patient that is symptomatic and has both quite high risk of thrombotic complications and bleeding complication. Now you can see the CAT scan. The blue arrow is a drainage of hepatic veins into right atrium, and the yellow arrow is a two inferior vena cavas that goes into azygos vein that flows into superior vena cava. And we are going to use the FARAVIEW system with the pentaspline catheter FARAVIEW nav that allows us both mapping and ablating. And for occlusion, we are going to use Watchman flex. Thank you.
Okay, can you guys hear us okay?
Yes.
I don't know if they can. Yep. Can you guys hear us okay? I can't hear them.
I can see images, but not.
They can't hear us yet.
Yeah,
So.
I can hear, but I can't see you.
Oh, you can't see it? Are you sure you can't see
Okay,
it?
all right. Now it's perfect.
Okay. Okay, great. Okay, so as you heard, so this is a patient with a congenital absence of a traditional IVC. So the approaches are obviously we can do transhepatic or we can try to go from jugular. We decided to do transhepatic in this case, and we can talk about why and if you'd like. So what we'd like to do is to go live, do the transhepatic puncture, hopefully. Then we'll have you go over to the other lab because Honza has a PFA case with a novel PFA technology. And then when you come back, we'll finish the remainder of the case, okay? So what we have right now, hopefully you can see. Okay, you can see actually, this is a transthoracic probe we have there. And you can see the confluence of the hepatic veins right there. Let's try it this way a little bit. Yeah, perfect. Wait, a little more. Yeah. So you can see and you can see the depth. It's about 15 centimeters to the heart, right? And that's a nice couple of veins right there in the center. So now what we're going to try to do, hopefully, where's the angle? Okay, so, tell me when you're happy. Okay. Okay, and then fluoro. So this is the approximate direction I want to go. Yeah, let me see. I'm gonna go. Oh yeah, we can go apneic now, please. Actually, no, don't go apneic yet. Let's wait until Do you see me? Not yet. I don't see it. Yeah, it's okay. We can keep breathing right now. I'm in a little bit. You know what? Let me just give a little bit of contrast. Yep. I may be far enough for all I know. The key is not to give too much contrast here. No. I think I'm outside the capsule still.
Capsule, yeah.
There
it is. I see you. Right there. Let me find you. Hold on.
Let's go apneic now, please.
You're on the capsule.
Yep.
And you're straight looking up. Yep, see it?
I think I'm in the right
Yeah,
direction.
you're in the right direction. Keep going.
There's a
Hold on,
small.
hold on. You want to just give a little contrast?
I did.
Yeah, right there.
Yeah, I think I'm right there. That Pinky branch. I don't want that branch.
Huh? There you go. That's very nice. Right
Nice.
there. You're,
Like that.
yep. You want
The-
contrast?
No, I just gave a little bit of contrast.
Okay. Let me do it.
Got this goddamn wire. Okay, there.
Got it?
No, okay, hold on 1 second. Getting the wire into this thing is like not easy.
Okay, you good? Perfect.
Okay, there. Okay, so now we're in the vein
All right, just
and in the heart.
go down a little bit.
Let's just look at the heart.
Yeah, there you go.
Yeah, okay, we're good.
Perfect.
So now what we'll do is exchange over to one of these things. This is just like with the Paracross device. You can put this angioplasty size wire in, and then we can exchange over, we can breathe. We can exchange over to the Amplatz wire. So now what we're going to do is put a bigger wire. Oh, just lost the,
Don't worry.
okay. Just make sure it looks good. Looks good.
Let's go to the 16 sheet.
Now, one of the keys with this in terms of preparation is you got to make sure, unlike vascular access, right as soon as you take out the sheath, when you put a sheath in, right as soon as you take out the sheath, it's going to bleed like crazy. So it's important to have a short, large sheath that will stay in until the end of the case. So whatever you're planning on doing, you got to make sure. Let's stick this wire all the way up.
Yep.
Is it going up?
No, not yet.
No, it's not going up
Keep
yet.
talking if you want.
Yeah, why don't you work on that? So you want to make sure that we can actually have a big enough short sheet so that anything you do, you're going to go through that short sheet. So that at the end of the case, when you're taking out the short sheet, you can plug immediately. Otherwise, you can't exchange. You know what? Let's just switch over. It'll be okay.
Yeah, we just go.
So we'll do is we'll put so we have a, we're planning on putting a Watchman device in. We got to get the fair drive in. So we have a short 18 French sheet. This is 18 French, yeah?
Yeah.
Is it 18 or
18.
16?
18 French.
Yep.
So let me have this
Just
one.
like it.
Okay, you got it?
Yep, yep.
Okay. So this is a big sheet. So once you put it in, you don't want to take it out again. This is going to be a hard
need a
part.
bigger-
Oh, I need a bigger neck.
Yeah, Nick, please.
Watch your fingers.
Yep. Okay, good.
Okay.
I got it.
Okay.
So we could just go with the sheet.
We could probably just take it right there.
got it, yeah.
Let me track
Yeah,
this sheath up.
perfect.
Okay. So I think, any questions at all about this access? You guys take the wire, please.
Yeah.
Is
Dan,
this
any
a
questions?
special needle or
It's just actually a
super
spinal
thin or-
needle. So it's just a spinal needle. Basically, you just got to ask the anesthesiologist what they're using for spinal access, and that's the needle that I typically use. It's nice to have a longer one, like 15 centimeters, but as you saw, in this case, even 10 centimeters is probably more than enough. But I like to have a longer sheath in general, or needle in general. What's that?
Tell them about that.
Oh yeah, so the other thing in terms of access, let's just show this now.
Yeah.
So if you saw that the azygos in that, you saw the azygos that came together, I'm sorry, you saw the veins from below, they came together, two azygos joined behind the left atrium and then joined the SVC. So actually, right now, you can see Davey has let me just quick sync here. Hold on a second. So we actually have a venous access, an ephemeral access, and you can see actually that's actually the ICE probe that went up, joined into the SVC, and then came the azygos SVC down in the right atrium. So on the ICE image that I think you have on the top right, that's actually the transeptal, the interatrial septum. So we'll do the transeptal now. And I think in the interest of time, we're going to have you go over to Hunza because this is just a regular transeptal at this point. And then when you come back, we'll have some other interesting aspects to the case.
Okay, see you later.
Yeah. Okay. Hunza, it's your turn.
Ale hovna Honza, vole. Ty tam máš Honzu. Počkejte, tak já půjdu tam, ne, já půjdu tady, jo. Uvidíme, tak já pak to sklopil. A pak to dáš na ně, jo. OK.
think we are in a good position. So
Can I hear somebody?
Yeah, we can hear, we can see.
I cannot hear
You are
anybody.
online.
Okay, very good. Okay, so Dan, can you
Yes.
hear me?
Yes?
Very good. Okay, perfect. So, guys, so we'll be change the schedule because the transhepatic was really very important to show live. And then we have now a mesh catheter, which was developed in Czechia, fully in Czechia. The company named BTL was a producer of EKGs, Holters, etc. And they decided to get some huge investment to the catheter. So I need to congratulate them to make this risk, okay? It was very unusual in Czech Republic. So going to the case. So we have one very young guy, even not 60, and he was chief of medical technical team in Homolka, and he got proximal atrial fibrillation actually like a year ago. And then he decided, because he knows us, so he decided to go for the procedure, and it was really fully paroxysmal. So we decided to show, okay, fine, you are a technician, let's try this guy. So he is part of the study. So we run the study, and I will show you later on during my presentation all the data, so we don't waste the time. Now I would like to stress that all the development in Animal Lab, which is our Animal Lab in Albertov, where is like student revolt in 1989 started. So we have a very nice Animal Lab now, and all the experiments mostly done by Stepan Havranek, who is here with us from the Charles University, and by Pavel Hala, who is our original EP fellow, now is attending. So I will show the catheter, and I will then continue with the case directly. So if you can focus on this model represents right-sided veins. Actually, this right inferior is like too much branches, so it's not suitable for showing anything. So this is the catheter, mesh catheter, which represents like 32 elements, which are recording, which are really pulsing. So the good thing is like bipolar, but the cluster of bipolar means that if you have collapse status of the catheter, even in collapse status, it was not any arcing. So it's no arcing issue. It's one of the unique catheter without any arcing potential. So if we, it's over the wire, you see the wire, and actually we have the catheter in the position of the right upper. So you can use the basket pose shape and make it very conformable. So very conformable. You can push it, and actually on the floor, on ice, you really appreciate all the morphology changes. So the principle what we are doing now today for this proximal atrial fibrillation patient is just only single shot, one shape in the basket shape and one in one other position in the disc position. So actually we are, in terms of protocol, we are using only two pulsing in the basket and the disc. So I will show you the disc shape, okay? And you can see that the catheter is really conformable. So you can even push to the ostium, you can be really outside, you can go really antral, and you can even help with the sheet behind to adapt the shape of the catheter. So with this, I would ask guys to show the case, and Toshi did the CartoMap. Actually, the case we started always with baseline map, and then we continue. Okay, Toshi, it's yours.
Sure. Okay. Okay, let's move on to the case. We already prepared some stuff to save our time. Let's keep going on. I can explain during the case. Okay. We are in the first position in the left superior vein. Look at the. Okay, you can ablate.
Okay, we are in left upper pulmonary vein. We can see nice signals. We can see good contact on ice, and also there is a donut and purple color showing us that we have good potentials. So we are ready for ablation.
Actually, this is 2D 360 view, like a little bit like anatomical, electroanatomical picture. Okay, very primitive, but it's like starting point. Okay.
So Můžeme jablovat, vypneme trouhelník.
Okay? So please shadow
Okay.
and switch off the magnet. So we need to switch the magnet, right? Okay.
Okay, we can start.
Yes, we can start. Okay, this is the first application. Today we have just two punctures on the right groin. One is transeptal with this catheter, and the second one is ice probe. Oh, and the patient has a little bit thick septum here.
Actually,
Now you see the left inferior vein right there.
we are using like this train, like 4 trains per 3 trains, right? 3 trains or 2 trains? 3. So 3 trains per position, but we are not changing the position. So we are not rotating. We are not even changing position. So 3 pulses. Now we will switch, and Stepan will switch to the disc pulse. Okay, very nicely visible on ice.
And also on
Very
photo
nice.
we can see it as well. There are a little bit change on donut. There are some potentials which were ablated. Nowadays, check on X-ray as well. We are in good position, so we can continue. Switch off
You
capital.
see the cut map.
Shadow.
You see the
Switch
one
off.
ring and 2 bars. When we have a basket, the 2 bars are crossing like this. And when we change the shape to the disc, these 2 bars will be parallel like this.
Okay, let's start. Let's ablate.
And we need to visualize because of the catheter is not with any magnetic sensor, okay? This is only impedance-based visualization.
What is the diameter of the catheter in this configuration?
Very nice. Very good question. Actually, in the collapse status is 8 millimeters. In collapse status is 8 millimeters, and we potentially can use it for linear lesions. In the max pulse, in the disc shape, is 33 up to 34 millimeters. Okay, depends on how you push the disc. So it's 33, I would say like 33 millimeters max.
Okay, we are just finish
So we
first
are finished
vein,
with the
so we
left
can move to
upper.
the left.
And please go,
Inferior.
the guys will show you to go like to right, left, inferior. Actually, you know, actually it's obviously. Actually, the map showed a very nice result. Okay.
Right there, we're there.
We are there.
Coloration
Just
of
open the
left
catheter.
inferior,
So
perfect.
we are in the second vein. Floor is okay. We see it on cartel map as well.
Okay, we can go. Now again, look at the color map. You see the small red just right down there. That's the previous lesion from the left superior vein. So the catheter has no significant X-ray marker, but you can see where we are and which part of the basket is up and down and anterior posterior from the color map. So this is
The third
the
one.
third one.
Perfect. So we will switch to right upper, but before then, please guys show the conformability. So we can show like when you have a disc position. So please like now disc,
Yeah.
now
Disc.
disc, okay?
Now I
so
switch to
when you
disc.
switch to disc, pause. Okay, it's perfect. So you can adapt in the floor like the positioning, okay?
It's
of
better
the catheter.
position like that. Just check on X-ray, okay?
And for sure we are using ice as well. It's not super broken, but you can see on the eyes good apposition, a good contact.
So we always check eyes and signal from the Pulkar and signal from the color map, and then you can do everything all together to get the good best contact.
And during the protocol, we are doing now like in 2 centers. It's like in Charles University and Homolka. So Stepan is responsible for Charles, and we are responsible for Homolka. So we are able to treat even the persistent patients because of this disc pulse, this disc configuration. You can easily get adapted the catheter against the posterior wall. Okay. So
And Peter, when you mentioned that potentially the catheter can be used fully collapsed, is it possible? Because, for example, with Farah wave catheter, it
it's-
is not possible
yes.
because you can't deliver fully.
It's perfect point. Again, I repeat it, I already stressed. In collapse status, in 8 millimeter collapse status, even the wire is helping you to position the catheter. You can
Maybe a little bit
use
back.
linear lesions. It's not allowed through the protocol, but potentially in the, other and further development, we will be using as a lines, okay? So we didn't use for mitral, we didn't use for CTI now, but actually for CTI we are using mostly the disc dispose, as we know from pentaspline. But I think I'm very optimistic to try to get the linear lesions by the collapse status of the catheter. Because it's no any arcing, so it's perfect. I don't know how they did it, but they did some. They said like clusters, bipolar, something. So it's no any arcing. Okay.
Are there any questions from the audience? Not yet.
Oh, look! You can see on the floor a very nice adaptability of the catheter, on the shape of the catheter on the right upper. And actually, we can use more lesions on upper left and right, but arbitrarily we don't want to overshoot. Okay. Actually, if you want to move to some other lab, it will be finished very soon. So if you want to stay with us till the right inferior, it will be nice.
Yeah, we may wait
Yeah.
because Vivek is not yet ready for.
Ready? Oh, ready is not ready. Okay, nice.
So we are in this position.
So let's enjoy this. Okay, so it's perfect.
Okay, we can ablate.
We are right inferior.
Inferior.
Okay, we are right inferior now. Okay, go shadow, switch off. No, switch off like that. Okay, perfect. Perfect. Switch. Okay. Okay.
Yeah, we can.
Go. Perfect.
We can ablate.
It's a little bit tricky then, because when we need to just adapt the anatomy, because we really want to use the same anatomy for, remember, we did this anatomy by octa-ray catheter, which is arbitrarily used for this particular study. And actually we will expand soon to other Czech centers, so hopefully within some weeks, even ICAM, then PEPA. No, I know, but they will start, right? And others, right? Maybe Olmos? I don't know. Who else? Oh,
So,
Bruno.
we
Okay,
can move to
as well, Bruno.
last vein.
Fine. Okay. It's a nice scanning of the upper vein. Let's not go. Now it's there. Now it's there.
Yeah.
Perfect. Okay.
Yeah,
Nice guys. Okay. So we are going last vein, as I understand. Okay, last vein.
Yes, this is the last thing.
Okay.
Okay. Yeah, we
Actually,
can
the
stand.
right upper is a little bit like I would like
Yes,
to
the
go
shadow.
more
Shadow.
applications, but it's up to decision, up to operator decision.
Okay, we can ablate.
Okay, go. And actually, we are able to look from the left atrium from eyes, but no, in this case we didn't push the eyes to the left. In FaraView and FaraWave cases, we have like majority of these cases since last year or since I don't know what, really in eyes in left atrium position. Because it's easy to go there, right? Okay. And specifically for right inferior, right upper veins, you have much better visualization from left, I would say. Okay? So, perfect. So this is number 3. Okay, perfect. So
Okay.
last position, last disc. Okay? So if I count well, we are ablating how much?
Snapshot.
5 minutes? 8
go,
minutes? 8 minutes ablation now? 8 minutes,
8
perfect.
minutes right now.
So 8 minutes right now. So in 8 minutes we are done with. Actually, I don't want to be like super speed. Like I don't care. I care more about the remapping. Actually, I will show you during my presentation the results. I don't want to open now because it's part of my presentation. Will be like 11 or so. I don't know. Right. Okay, exactly. Okay. Dan, any questions?
No, there are no questions from my side,
Please?
not from
Okay.
audience.
Please. Go ahead.
What do you do just now? You will do remapping or pacing from veins
Yes.
or
We
what?
will do remap to check all the
Absolutely.
lesions.
Exactly. So now we will pull the catheter out of the body. We will stay with. Actually, we forgot to stress that even the sheet is the own production. So because since 2 years we use like far drive sheet for this catheter. Now we are using their own. So it's like unique assembly. Okay. Perfect. So any questions?
No, I think case was straightforward, so there's nothing to ask.
Okay, perfect. Okay. So enjoy the morning, please. How many people are there? Like 10 or?
No, more.
No, perfect.
I
Okay.
maybe
Nice.
more than
Very
50.
good. More than 50. Great, congratulations.
Oh,
Till the morning.
If we can continue, we can just
Do you
finish
want
the
to
case
show-
in
Dan,
5 minutes.
Do you want to show I don't know if you care about the voltage. Do you care about? Well, do you want to see the voltage?
Yeah, of course.
Okay,
Yes.
let's go. Okay,
Perfect.
Toshi, it's your turn.
Yes. So let's quickly map and. Oh, we got the dissociated spike.
Actually, I must say I love this Octaray, and it will be even better. Hopefully, very soon.
LIPV
It's-
update.
So the high
Let's
density.
quickly check all the veins.
Okay.
RSPV, clear.
No signal.
RIPV,
You are out or you are in?
I'm out.
I will show it.
Okay, out.
Nice.
Okay.
You are in.
So
Now it's
if you are in, it's okay. Okay, now it's nothing. Now
Okay.
it's 0. Okay. Going a little bit, you are maybe in the right inferior, you are too much or still, I guess. Maybe. Oh, too much or still is the. Okay, because look. Okay.
Okay.
Probably.
So seems to me that the veins are really isolated. Actually, we stress. Dan, I will add something more. We always a little bit worried in these proximal patients about the posterior wall when we are so close with the disc shape, left and right, and it should be created, and we don't want to create the corridor on the posterior wall, okay? So this is something we really care. So that's why we are a little bit more inside the veins, more hostile than antral, okay, in this case. But if we know that we are continuing with the posterior wall, then I don't care. I would just like push it, whatever. But we can discuss if we really want to exclude the narrow corridor on the posterior wall. I would love to know any, okay?
Or will you do
Okay,
posterior wall
stop.
just now, or you are not allowed because of study?
No. It's this proximal atrial fibrillation. If we have persistent, we can do that. Okay, we did several. Okay, so we are able to do posterior wall.
Yeah, of course, but will you do this in this particular case? Because even
No.
in paroxysmal case,
No.
the ablation of posterior wall might be helpful.
No. I mean, the corridor is not so narrow. It's like okay. So I would suspect okay, it's no potential for too much reentry on the.
Yes.
No,
We
I
just
don't
finished
mean
the map.
just to prevent the roof flutter, but just ablate the arrhythmogenic part of left atrium.
Oh no! Actually, you know what? I understand now the question fully. It's interesting question, and actually, in some cases, I would do it, but not this, as he is like our employee or whatever. Okay, so we are finished.
We're done.
So, any questions, guys?
No,
Any
I'm
more
asking
questions?
again, and there is no raised
No.
hand. So we may
Okay,
go back
so-
to Vivek if it is possible, because ICAM is not
Okay.
yet ready. So we have
Fantastic.
to go to ready.
Ready for...
Turn the volume up, Prasim. I can't hear them. Okay.
All right.
Yep. Okay. Can you guys hear us?
Yes.
Okay. Great. We're just working here. They're gonna bring up the images. Ablation. They're gonna bring up the images in a second. So what we've done, you guys, what we've done is to do a transeptal puncture, as I said. We're gonna do one posture while here too. Ablation, Prasim. We're going to do so we did the pulmonary vein, we're doing the pulmonary vein isolation. You guys bring up the images for them. I don't think they can see anything. Okay, they're working on bringing up the images. But basically, ablation, we did a transeptal puncture, and we're just finishing the veins right now. I think that's probably good. Show me an AP view, please. Oh, perfect. Okay, you guys are seeing. So what we've done, actually, let's just show on fluoro here. You see fluoro, yeah? There you see it. So we have a big sheet that you can see down there. That's a 18 French. Through that we have the Fair drive. Through that, obviously, we have the let's do 2 more lesions here. I want anterior ablation. Through that we have the catheter, the Fairwave catheter. I don't like that pedal. Okay, that's good. And then 1 more lesion. Ablation. So we just did PVI and posterior wall ablation. It was sort of a left common. Now what I want to do is to render the anatomy. Great. Okay.
Okay.
So you're going to get a 35?
24 by 20, you could do a 20, 31 really.
Let's do a 31 then.
31,
Spread it. Okay, I'm just going to finish rendering the rest of the anatomy. Now, one of the things, okay, let's start collecting. One of the things we're going to do now, so basically, as far as I'm concerned, we're done with the ablation part of the procedure, okay? But one of the things that we're doing is something called stunning the appendage. Let's keep collecting, please. Why is it collecting so slowly? Forget the triggering, or trigger off of anything. I don't want the QRS. You can do anything, actually. I guess I've noticed that the left atrium is always collected very slowly when we're in a live case. Okay. So one of the things we're going to, okay, let's show the TIA. Okay. Tomasz, can we show them, I want to show them the appendage and show the, yeah, okay.
Perfect.
Okay.
Right there. You have it right there.
Yeah, so there's the left atrial appendage, and we made the measurement start as 24 by 22, okay? So we already know what size device we're going to use. But, you know, one of the questions is, leaks out of the appendage is always a problem. So what we're trying to do is something what we call stunning the appendage. So what we're going to do is basically ablate in the appendage. Hopefully we'll isolate electrically forever, but practically we probably won't isolate
Nitro,
forever.
right?
Yeah, well, let's get the nitro ready.
Nitro.
So what we do is basically deliver lesions inside the appendage, and what that, you guys, keep it down. Ugh, they're like screaming. So what we're going to do is ablate inside the appendage to mechanically stun it, and then when we actually put the Watchman device in, the chance of it, congealing and basically not having a pair device lead becomes much higher.
Tomasz, can you get a pulse wave Doppler in there?
Yeah, one of the things we like to do is to get a pulse wave before. So, Tomasz, let's do pulse wave.
Yeah, he's getting.
Okay. So there's the appendage, and what Tomasz is going to do is get pulse wave. It doesn't look like it's that much, but we had a better one before. I think we need to be a little more coaxial, Tomasz. Yeah, there. That's better, I think. Okay, let's do the pulse wave. Okay, there we go. Let's see that.
Gain it up. Maybe
Can we gain it up a little bit? Yeah. Anyway, it's okay, Tomasz. Let's go ahead and get ready to ablate. Do we have the nitro?
Yeah, nitro is coming.
Okay, good. So when you do this, obviously you don't want to perforate the appendage. So what I like to do is to first lead with the wire. Then we can put the device in position. Tomasz, let's just watch this. Okay, perfect.
Yeah, go
Nitro's applied? Okay.
Nitro is in.
So what we're going to do is, let's just render the anatomy here.
3 milligrams.
Okay. So you can see, of course, that the coronary artery is closed. So that's why I like to, we like to give, get this a little closer. And again, look, we don't,
That's good.
yeah, this is actually pretty good.
That's actually good.
Now, where'd it go?
You just came up.
Yeah,
Move it in.
hold on, where's the wire? Okay, there we go. No, it's actually better if it's further back.
Right there is good.
Okay, let's go ahead and start ablating here, please. Okay, ablation. So again, I would like to electrically isolate the appendage. If we do, I'll consider that obviously a good thing. But really the goal, ablation please. Really the goal here is just to prevent, and then I'm going to rotate here, it's to really mechanically, as I said, stun the appendage. Again, please. Ablation. Okay. Yeah, can we rotate the thing so left lateral so we can see?
Left lateral view.
Yeah, left lateral on the opal, please. I want to see down the barrel. Ablation, please.
Keep going. Please keep.
Keep going. Rotate. No, I want to see down the barrel of the fairway. Let's look down the center of the fairway, please.
Yeah, keep rotating.
Yeah. Perfect. Ablation, please.
Yeah, that's exactly.
Yeah.
A little deeper.
Yeah. Now, so I did basically 6. Then I'm going to put it a little bit deeper. And actually, you can see there's actually very little potentials in there right now, but that's okay. Let's ablate it again anyway. Yeah, ablation. Notice again, we're leading with the wire, okay? So the wire is actually the first critical aspect. Again, please. We need the Watchman sheet too. Okay.
Yeah, perfect. Thank you.
Okay, 2 more, please.
Flip with you, okay?
Yeah.
Give contrast.
Any questions so far?
On the
Are there any questions from the audience?
Yeah.
Not yet.
Okay, last one. Go. Now, yeah. And then see, AP view, please, and continue to render the anatomy as I pull out. Just get more anatomy just for posterity's sake. Add anatomy, please. On opal, add anatomy.
Yeah, this is good. Perfect. Yeah, this is.
No more ablation. We don't need to ablate anymore. We're done.
Yeah.
Can we add anatomy on opal?
Sorry.
Yeah, just add anatomy. Screw it. I don't care.
You want to take it?
Yeah, we're going to take it out.
There you go.
Okay, so this is good.
Can
Hold
you
on.
fly
Let me
the syringe, please?
let me aspirate here. Every time you take something in or out of the sheath, obviously you have to aspirate because you can enter a lot of air into the system otherwise.
Take the fairway. Go.
Yep.
Voice across.
Okay.
Got it? I got it.
Okay, hold on. Let's see where we are. So we're just going to, I'm in the appendage. That's fine. Okay, so
You want to just put it in the.
you want to track this out?
I got it.
Okay, track that guy out. I got to hold this sheath
You
because
got
it's
sheath?
very stiff. Yeah.
Okay.
Keep going. Keep going. Oh, wait, hold on. Wait.
What?
Okay, that's good.
Okay. All right. You have one?
Okay, let me have the other sheet.
Got it. I got it.
So we're just exchanging, and this is what I meant before by putting in the short sheath, because if we didn't put the short sheath in and we're trying to exchange over this, right now it would just be bleeding out into the abdomen.
Got it.
So, okay, let's take
I
the,
got it.
get it out?
You want angio or no?
No, I don't want
No.
angio.
Okay.
I
You
just
wanna go
want
with the device?
Yeah, let's go with
Okay.
the device.
All right. Let me do the flash now. Check it out. Okay. there
Hold
you
on 1 second. That's not, okay, there we go. Definitely bleeding properly.
go. Let me know when you're ready.
Okay, aspirate, please. Got it? Okay, good. Flush. Okay. Okay, that's good. Close this one.
Yeah.
Contrast, please.
Contrast.
Okay, so now let's do the Watchman device. The tricky part here, unfortunately, we don't have a deflectable sheath today, and that can be challenging sometimes.
You're right onto it.
What's
Just
that?
go to ball and just manipulate. You'll go in. I think you have to counter.
Yeah. We gotta.
Counter it.
So right now we're a little too low.
There you go.
That's pretty good, right?
Tomas, can you biplane for me?
Any contrast, please?
Yeah, there, right there.
We're gonna do just a contrast injection here.
Yeah, very nice.
Notice how the flow in the appendage is really, really slow.
Yeah, you
That's
good.
what.
Yeah.
The other thing, by the way, is when you do the. Am I there? I
Yeah,
don't
you're
see
good.
him.
You're good. I would just slowly start deploying.
Yeah, we're gonna go ahead and deploy here quickly.
There you go. Perfect. It's good. It's good.
So there the device is
There
deployed.
you go. Like nice. and-
Question is it too
Com-
steep? No,
no,
I
it's
think it's
not.
actually
It's not.
pretty
It's
good.
actually very
That's
good.
pretty good. Let's do we'll do a contrast injection. Give me a little Ario, please. Tomasz, watch your legs.
Put your legs too much. I'm gonna do a little caudal tip. Maybe.
Okay.
Let me see. Fluoro.
Contrast, please.
I can take it.
Fluoro for me. Let me just set it up.
Okay. Tomasz, I'm going to do a quick cine here. If you want to get out of
Back
this,
it up just a little bit. There you go.
step back.
Press. There you go.
This is, okay.
Okay.
So,
Thank you.
here we go.
Yep. Good.
Oh.
We need to come back. Ooh, 35.
We should have taken a bigger one.
Yeah.
I mean, look at this though. There's so much.
much.
I don't know. A bigger one's going to make a difference actually, because you see
Just
these
come-
proximal
I would
things.
just come back. You
I don't think we can, because you see it'll end up this. I don't think we can actually cover that part.
should try it.
Can we get a 35?
Yeah. Let's get it 35.
So, if you don't like the position, you got to take it out very quickly. Otherwise, it'll clot quickly. Yeah, we'll take a bigger one. Yeah, that posterior lobe is annoying.
Yeah. You got it. There you go.
You got the 35?
35 coming.
Okay. You should have prepped both anyway. Okay.
Yeah. 35. You want a 40?
No, I think we don't have enough depth for a 40. We'll end up with a proximal leak. Yeah. I mean, honestly, in this one, this is an appendage where practically something like an amulet may actually be better because of that, you know. But I think that I think the Watchman will be okay.
We'll get it in a second.
We don't have too much time to prep.
Yeah,
Let's
no,
just
no,
go ahead and
no.
put it in. That's good enough.
Let me get a flashlight. Over.
Yep, I'm putting it in.
Okay, go.
Aspirate there.
Hold on.
Yeah, it's coming in. We got some more air here. Yeah, good. Perfect. Okay, let's get in.
Okay, good.
Okay.
Good. Okay, go. Just go.
I need some more.
You probably have to start that deep though, for it to.
Yeah, we have to start deep. I agree with you.
There you go. There you go. That's perfect. Actually, I
Yeah.
would start right there. I'll start
Okay,
right
here we
there.
go.
Yeah.
Because the tip is going to have to cantilever
Come down.
over.
I will pull back a lot more. Tomas, can you show where it is proximally? I think you have more. You have, let me get that contrast. Hey, where's the contrast?
I think I can pull it back more too.
No, but like the syringe.
Syringe, screwing syringe.
Uh-huh.
Holky, dajte nám šroubovací desítku.
What do you think about that, Tomasz?
I don't know what he did with it.
We need to be further back, or you like
A
it?
little more, maybe. Did I? Yeah, thank you.
Can you show me in the other view, 135? I want to make sure it's not. No, see,
Yeah,
this is the
you're gonna
problem.
come back.
No, it'll end up
Okay, do the
leaking
contrast.
past. Let's do a contrast
Yeah,
injection.
here you go.
I'm going to do a cine, Tomasz. You're going to step back, please.
You have more room to come.
No, see, this is. I
Don't
think
worry
this is
about
it.
it. Let's
I think the
take
proximal. We can't. We're not. If I come back anymore, we may end up with leak around this thing.
This is good though.
Well, maybe we could come back.
Maybe
Show
half.
me, Tomasz. Can I come back anymore? You know, this is
Tomas,
deeper than I
should we
usually do.
Uh-huh.
I'm going to cut it coming back.
Let's do it one more time.
I'm going to
Worst case, You
recapture.
can always put it back in there.
Yeah, I'm going to pull back a little bit more and redeploy a little bit more proximal.
There you go.
That's actually a little better, I think. I hope.
Tomas, that's a little more proximal, right? There you go. Just use this. Back end it.
Okay. Step away, Tomasz. Cine. I think this is as proximal as we can go. If we go any more proximal, we'll uncover this. So we're going to take this one, and I'm going to so there we just let go of the device. Notice again how much contrast that held up because of the stunning. And we're going to actually be presenting some data on this pretty soon.
this out, okay?
That when we do the stunning effect, we think we have a pretty profound effect in terms of reducing peri-device leak.
I'm going to prep the occluder.
Yeah. So now we're basically done with the ablation. We're done with what we want to do in terms of the heart. So now we have to deal with the liver.
Flush line.
So the goal here now is to close the tract, right? So one of the things I like to do, let's put a wire in just to maintain access.
Okay, yeah.
So-
Let's get the cross wire, please.
No, not the versiprocessor. We need something straight,
Oh,
actually.
straight wire.
Yeah.
Vivek,
Yeah, the amplas.
Vivek, before of closing,
Yeah.
what is the current heart rhythm? Is it AF or sinus or what is this?
The rhythm is AFib. We will cardiovert.
All right,
For
so
sure.
you will cardiovert
We can
just
actually
now,
cardiovert now.
just to see if, because of difficult access, if you prefer to do more ablation somewhere else except of PVs and
we're
posterior
not-
wall.
Yeah, no, it's a good point. We can do a cardioversion now. Let's go ahead and do a cardioversion now, please.
Synchronized cardioversion, please.
Pojď na tu kardioverzi, jenom
You're
rovnou
gonna put the wire
bout
while you're waiting.
200.
I'm gonna unzoom, okay? Just for just a second.
Yeah,
Right, ready? You wanna put this?
yeah, yeah.
Let's go get that ready. Okay. Oh, that wire's gonna leak. Are we atrial pacing, guys? Can we pace at 80?
Yeah, I think it is. It's just that we have saturation artifact here.
Yeah.
Stupid thing. Yeah, yeah, I can see it there. Okay.
Atrial pace.
Can we do AV sequential pacing?
Yeah,
there?
they do.
Oh, they are.
got
Perfect.
it. Yeah,
Okay.
perfect. Thank you. All right, let's go.
Okay. Now, what we have here, actually, can they see on me? They can
The
see me,
camera,
right?
please, on the amplats occluder.
Yeah, so the plug, this is what the plug is. This is an AVP2 device. Can they see this?
Yeah, there you go. Please.
Yeah, this is an AVP2 device. Can they see? Yeah, they can see it, I think.
Yeah.
I hope, so it has 3 different segments in it. They're very soft. It's a 10 millimeter device. We always like to oversize. This may be a little too oversized, but that sheath is an 18 French ID, which is probably a 21 French OD, so maybe 8 millimeter hole.
Yeah.
In the liver, it gets a little fuzzy, so we like to use a 10 millimeter, so I think that's reasonable. You know what? We may need to use a, we need like a, I need an 8 French sheath.
Eight
Yeah,
French,
get me an 8 French sheath. You need to have some sort of if you try to put this by itself through a very large sheet, it doesn't deploy properly. So we need a shorter, we need a smaller sheet that we can put this through. And then what we're going to do is we need to find the actual, just give me the transeptal sheath. Yeah, that'll be good.
Okay.
No, guys, I need a transeptal sheath. Give me an SL1 or something. SL1 sheath. SL1, SL0, any SL type of sheath. Yeah. Yeah. It's okay. And then let me just have the sheath. I don't need a dilator, just the
Yeah, just
sheath.
bring it.
Yeah. Okay.
I'll flush it here.
Here we go. So,
You don't need dilator.
no dilator,
No
it doesn't
dilator.
matter. Okay.
Okay, go.
Okay, so we can put this through here.
yeah.
This should be long enough, yeah?
Okay, well,
Let me just make sure it comes out the end. Good. So it'll come out the end of this sheet, so that'll be good. So we'll put the SL1 sheet through here. Okay, this thing is going to bleed anyway
yeah,
up here.
anyway. Can I have dry gauze? I'm gonna mad that.
Okay, so this is okay. So our we got to find where the tract ends. So let's go back down a little bit.
Okay.
Let's go down right down here. Okay, that's good. And then I have the wire in there just to maintain access. Okay, this is probably about where I want to start thinking about it. Yeah, give me contrast here.
Go.
You know, we should do
Maybe?
50-50. Do 50-50.
Okay.
Because we don't need pure, I
Okay.
think. Here, yeah.
Yeah, yeah.
Otherwise, it gets
Yeah.
too dark. You can't see
Yeah, yeah,
anything, right?
Is it okay?
Oh, that's fine too. That's fine. Yeah. It's gonna come out
Okay.
here, okay?
Yeah.
Yeah, okay? So you can pull.
Actually, this is probably the tract right here.
Yeah, it is.
I think we're in the tract right now. So at this point, I'm going to turn it this way. Go ahead and deploy this one. Wait, hold on.
Ready?
Wait, go ahead, deploy.
First part is out, second part is out, third part is out.
Okay, so that's out. Do a quick cine here. So that's actually in position.
Zoom. You want to do one more cine so you can.
Yeah, Tomas, step back for a second. I'm going to do a cine here. Okay, ready?
Okay.
And then actually, let me do a contrast injection because I want to see how it is.
Yep.
So this is the first part. When we try to close this, I don't just like using this. We like to use this along with, okay. Oh, you know what?
Yeah, no, let me pull it back.
I think I want to pull back a little
Yeah,
bit more.
let
So
me
let's
get the device
recapture.
back, yeah.
So let's recapture it. You got it?
Okay, yeah, I have it.
Pull the big sheath back. Come back a little more.
Yep. Right there, maybe. You're at the bifocal.
Hold on, give me a second. I want to just
Contrast.
inject here. Yeah, I like this better.
Okay,
Give me,
ready?
wait, 1 second. No, hold on. Pull this back. Okay.
Ready?
Let's go ahead, deploy there. Okay, good. I like this position. Give me more contrast.
Yep, that's half and half.
Oh, that's half and half already?
Yep.
Okay.
Okay.
Oh, hold on. There's so much air keeps entering because of the
Yeah,
sheath.
but it should
No,
be
let me
okay.
just let it bleed. It's easier. No.
The sheath is
That didn't
so
work.
that's why,
Sheath. Oh, you know what? I can inject through here. This is better.
Yeah. Okay. Ready?
Hold on 1 second. Yeah,
Oh,
this is
much
good.
better. You want to go a little bit in?
Maybe. Yeah. Go ahead and
I'll
recapture.
Just
Recapture.
tiny, yeah.
Okay.
there.
Go ahead and redeploy.
Okay, yeah.
Okay. And then
Like that.
then now we can just
want
like
it more?
no. I think we're probably good. But go ahead and inject again.
All right, got
Yep.
it.
Go ahead.
Yeah, I like that.
Okay. Good.
Yeah, that's
So let's
good.
take this off.
I'm going to take it off.
Okay.
Okay, good.
So this is deployed now.
So you want us to keep it there, and then we do the gel foam?
We do the gel foam through here probably.
Okay.
Okay. Now, the other thing I like to do,
Perfect. It's actually in the vein.
yeah. The other thing I like to do is to put gel foam so this is a little bit, give me I need a scalpel blade, please. This is a piece of gel foam that we're going to use. I'm just going to roll it up and just shove it down there. It's a little crude, but it actually works really well in terms of stopping the bleeding.
Okay.
Watch out.
Yeah.
Okay. And I can just
What do
cut
you need to
this.
shove it in? Dilator?
Yeah, I need the 16 French dilator. We need to cut off the tip. In fact, what we need to do is I need to cut this tip off of the dilator. Okay, I cut the dilator.
No, you cut the blade.
I cut the blade. I need another blade, please.
Hele, holky, dejte nám ještě skalpel, nám dejte. Jo, rychle, to mám potřebovat skalpel.
Or a scissor. I can take either. That's good. Now, but I do need a blade because I got to cut the sheath.
Yeah.
As it is, it's hard. You can't really shove the gel foam down the sheath. So, where's my gel foam? Oh, here it is. Okay. So I got to cut the sheath and then shove this thing down behind
Make
it.
your scissors, so- What do you got? All right, ready?
Okay, this is going to bleed a little bit.
Yeah, I got it. Just poke a hole first. Yeah, there you go.
Okay.
Like that. Okay. What did that do?
Where's the let me have the gel foam. No, I need can you, let's roll this, just hold,
Yeah,
put
I
your
got
finger
it, I
here
got
just
it,
to
I
hold
got
it so it doesn't bleed more.
Okay. Be careful with the blade.
It's a bigger hole than
And
usual.
You do this back, okay? And then this. Yeah, we got it. Yeah, we got this.
Okay, this is good. Hold on 1 second.
Okay, got it?
Yep, let's go.
Okay, go. Yeah, there you go. There you go. Perfect.
See, hopefully it's still,
Yeah, it's still there. Okay.
I wouldn't mind putting one more.
Okay.
That would
get
stop
that.
bleeding, which is good.
Yeah.
It's always
There you
good to
go.
stop bleeding. Let's
Okay.
put this one in too.
You really want to?
Yeah, 2 should be good.
Okay.
These are all pretty big. Okay. I'll put a second
right
gel
there.
foam right
More behind,
next
yeah.
to it.
Okay. I got one more, just in case.
Uh,
It'll just de-strap.
Nah, that's going to be done. We're good.
Okay, all right.
Okay. There's some skin bleeding too. We can give some Protabane Prosím.
Pro tam holky dáme 3.
So anyway, are they still there? Okay. So now we're basically done. So we're gonna check the. We're gonna couple of things. We have to obviously check for abdominal bleeding. So one thing we got to be careful about, certainly reverse, so protamine full reversal, or mostly reversal. We still have a Watchman device. And then we'll do an abdominal ultrasound later today just to make sure that there's no abdominal bleeding.
This right there.
Yeah. So that's really about it. Any questions or comments?
I think there are no questions from the audience. I have no question. Do you have any? No. Just like nice case, one-stop PV isolation and LAO occlusion.
Yeah, that's a good point. Let me make a comment about that. It is one, because it's, obviously more than the usual access, we'd like to try to do as much as possible. Having said that, it is certainly possible to go back again. If for some reason in the future we decided we need to do more ablation or do something else, we've done multiple accesses in patients in the past over time. All you do is avoid the one tract and go to a different tract, or a different vein. So, but again, your point about trying to do everything at one point, I think, is a very good one.
Okay, thank you. So both cases in Homolka are done, are finished, and we will go back to ECAM. Congratulations to this complex case.
Thank you.
Pace character. Just pace character shortly to see a delay. Okay, good.
And hopefully the first case shown from ECAM will be the Ante Anic VT ablation.
Yes, it is, yeah.
Dual source.
Hello, everybody.
Hi, everybody. Greetings from ECAM, from EP Lab 3. We are here with Ante Anic, and we are about to show you a VT ablation case in patient with structural heart disease using dual energy SmartTouch SF catheter. Show us next slide. So this is a pretty young, 55 years old patient with a lot of comorbidities, and he had already 2 myocardial infarction, and the last coronarography was done in 2021, where they found a diffuse multivessel disease and without option for revascularization. Patient has a low ejection fraction of 30%. He has a really large left ventricle of 8 centimeters, and he has a big scar in LAD territory. He had the ICD implantation in 2020 as a primary prevention of the sudden cardiac death. He has optimal medical therapy and without any signs of heart failure. But in January this year, he was hospitalized because of the 2 syncopes, and there were several non-sustained episodes of the VT and 2 sustains with episodes of VF terminated by ICD shock. So amiodarone was prescribed and he was scheduled for catheter ablation. Can you show the ECG on admission? You see here a pretty big scar actually in the anteroseptal wall. The next slide. Here you can appreciate the extent of this scar in LAD territory. There is trabecularization in the apex, but no signs of thrombus. Okay, and now let's show them eyes just to appreciate this scar. I don't know if, yeah, do you see eyes? Okay, so here you see eyes and eyes images of the right and left ventricle, and there is actually a pretty big scar here and on the anteroseptum. For this case, we had both transeptal and retrograde approach. As I said, we are using dual energy SmartTouch SF catheter, and we are using Optrel catheter for the mapping. At the very beginning of the procedure, we induced 1 non-sustained VT. Can we show them the review screen of the Pruka, please? And in total of 3 sustained VTs that we had to terminate by overdrive pacing. The first morphology was exiting the inferior apex. The second morphology had exit more at the lateral part of the apex, and the third morphology had exit more anteroseptally at the basal part. And so we reconstruct the voltage map of the left ventricle during the sinus. where we see this low voltage at the anteroceptal region, and we had a very long SQRS in the middle of this scar. Can we show them? First of all, we had a prolonged conduction in the ventricle with a HV of more than 65 milliseconds. This is the longest SQRS of 75 milliseconds. And we had nice deep, let's show them deep signals. Okay, deep mapping, deep 1. Okay, signals, please. Okay, so here you can appreciate the delaying of this late signals. So there is some slowing at this region, and then maybe you can continue, Ante.
Yeah, I would say so far what we've done map, LV map, and the cardial map with Optrel. And you can appreciate that maybe in contrast to our belief, we found less scar so far, less scar than what we believe. Now, if you take a look from RAO view, more RAO view, now we have two, you see that the apical part of the septum and more to mid part of the anteroceptal region, there are two distinct islets of a scar, and you're right there between. So if you take a look at the electrogram right now, can we do first pace catheter? This is the region where we obtained a nice stim to QRS delay. Let's see if we still have it.
Live screen, please.
Broadcast screen live. Can we pace ablation catheter? Yeah. So this is the region. Stop here. Stop now. What's the output you're pacing at? 10. So we are pacing at 10. This is important to know before ablation. Now, can you do what I call protocol pace from RV? Just see what happens on ablation catheter. Previously, I spotted some delay. So can we do 4 drive? Yep. Yep. Yeah, we have it. So we have it. We have a delay.
Show them review, please.
So again, we are in the border zone. 1.22 is a bipolar voltage here. And I think it's fair to believe that this could be very ergogenic region. So we are satisfied with what we see. And we're going to start. We have a dual energy STSF catheter inside. We are using F-type. For this purpose, you will see on fluoro that you'll see that the catheter. The only way can we get to this large scar area, especially this aneurysm, is this large loop. And now I have to work on my contact. At this moment, I have around 13-14 gram of contact, which is good for RF. It's not good for PFA. So because for PFA, you would like to be around 20, only with 20 grams of pressure. And if you do full 24 train application, that takes around 23 or 24 seconds, you'll get to pulse field ablation index of 550. But here in ventricle, maybe we want to go more, But because when you combine, based on MLab data, when we combine good RF and good PFA, we can go deep, get as deep as 7 to 8 millimeters. And now one thing is a depth, one thing is a width. So if you are below, I'll start okay, let me improve the contact here. So now we're going to do 30 watts ablation. 30, okay, so I'm going to start RF. So previously at this spot, prior to this ablation, okay, now we are ablating with 30. Catheter is stable, so we should be having ablation index. So it's a good contact, 30 watts of pressure, 30 grams of contact. So probably I'll start by 650. When I reach 650 in the ventricle, I see some lesion formation there, I think. On ice.
Can you show them ice as well, please?
Okay, so it's a good contact here.
There is a whitening. But
yeah, but it's not dramatic.
Yeah.
Not dramatic. Let's go on.
Go on.
Yes, 650. So I'm going to stop at 650 and we're going to try and pace. So with 10 output, stop. With 10 output, show me. With 10 output, we lost capture. Okay, fine. So now on the same spot, go to PFA, please. Now on the same spot, we are stacking PFA. PFA on. So now during PFA, try and observe what's happening. Because do you see that we're stimulating the heart? Have you seen that first couple of our trains? You see, we are still stimulating the heart. Now take a look what's happening on my contact. My contact is going wild. I'm on the same spot. During RF, I had a stable contact. Now, because of this stimulation, your contact is less stable. However, look, we are close to 600. Fantastic. 604. Good. So we had a loss of capture. Can I see PFA lesions? So I really stacked that one against another? So yes, so PF, they're on the same spot. Okay. So now you wonder, how far can you go, how you have to go from this point to get a capture? So let's say, this is just a minor movement. So let's see here. Okay, let's try and paste here. You see, you have a capture. So just for you to know, just for you to understand that this lesion is not going wild like 2 centimeters away. So look, what is the distance? What is the distance compared to the previous spot? It's important for us to demonstrate this. So how far are we from the previous spot? It should be around, look, so 6 millimeters away from my previous lesion with 650 of RF and full lesion of 6 PFA, PFA index, I'm capturing tissue. So once again, please pace. Still interesting.
Yeah. And look at this. Can you show them the review screen, please?
You think we're changing?
Every time when we pace, go to 100 speed, please. Every time we pace, go to the left. We have a capture with the long QRS, and then this is happening.
You think this local capture?
Yeah, the exit is changing, so we have a...
That's good.
One is exiting up, and the other is exiting down. So it's probably a crossroads.
We're basically
here.
10? Yeah.
It depends on the...
Okay, let me see if I can
pacing.
improve the contact.
And this is reproducible.
Yes, okay. So I improve the contact. So now RF. Yeah, go 40. So now we are applying second RF lesion. We're going to stack. Now take care, Predrag. Okay, yes. Impedance is fine.
No, it's okay.
Good. So I'll go for 650. And as soon as I reach 650, I'll stop. No need to max out at this point. No need to max out a single source, like especially RF. I would like to stay safe without popping here. 650 here. Okay, go to PFA. 2, 3. Sometimes you have to wait for 2 or 3 seconds for the system to switch. Now, have you seen that we had a very stable contact during RF? And this phenomenon here might tell you why some of the early experience with focal PFA, we have been fooled because we didn't know what was happening during ablation. We thought that we have a good contact. So you see how the contact is variable, and it's not due to a problem of the sensor. It's really happening because we are stimulating the heart. Okay, so 580, so we're again very above. However, I would really like to target 600 ablation index. Okay, let's go and try to be more, septal and out. Here, okay, here. What is happening here? We are more lateral because some of the, look at this, signals. Okay, so now, can you pace and see are we resembling any morphologies of the VT? Because now this is lateral exit. Interesting, still inferior axis. This does not resemble any morphologies we saw. We don't have any significant, and we are in the border zone. So let's try and map something else. Huh? You agree? Or so some aggressive contact here. So just please mind that also we want to visit while we are live. We also want to visit this more inferior stuff here, like this. Okay, let's pace here.
Please, could you move this window showing contact force a little bit to the left because we can't see the contact force value properly.
Oh, sorry. Because it's hidden within, okay, I know.
And this lower window
so now
as well.
We are trying to
the lower window contact. As well, just to see the
pace here, it's very low voltage here. PFA index. You have to make that screen wider. You have a second row. Your ablation index is now hidden in the second row. Will be hidden. Okay.
It's better.
You will see it. You will see it for the next application. Can you pace now? Can you pace now, catheter? Now we still have some good delay here. Some delay, and we are getting closer to the VT morphology. Like
can we match the VT2?
The one with the more lateral exit. So.
Yeah, that one. Okay, 70%, but.
No. For one of the morphologies, we should be better.
The next one, next morphology.
Because we are negative. We're negative in D1.
85.
D1, we have good transition from V1 for V2. So I think it's an interesting spot. So, yeah, we can speculate about quality of the electrograms here. So now, for the purpose of this, now I have very mediocre contact here. So I can do, if I want to ablate here, which I need to. Can you paste again, ablation catheter? So now, it's changing. Okay, so let me work on a better contact here. Here, good. So now try pace, but now it's different. Now we are in the border zone of scar. Update. Okay, let's search for another. Let's go more toward this part. Now it's more interesting. This is signal now. Good. Take pacing here because we're gonna ablate here. Good. Can you do okay? Can you do remember what we call protocol pace to see if we have a delay here? So let's say RV distal 4 in drive and 2 extras. Too short, yeah. We haven't. Yep, yes, we have it. Yeah. Let's do it. Okay, so now back to RF. Sorry, I have to improve contact here because, so 40 watts here. 40. Okay, we are ablating with RF. This is more apical part of the scar. This is a boring, good old VT ablation with focal solutive catheter. So nothing interesting happens here at this moment. We have to go around the scar. We have to check these exits. And of course, we will do also a fair amount of ablation inside the scar to homogenize.
So here, in case of
40.
Ante, here in case of RF,
yeah,
you are compensate the relatively low contact force by higher output, higher energy.
Absolutely. Absolutely.
What do you do in case of PF?
I have to improve contact. Look, so 650 here, sorry. So 650 stop. So try pacing now. I just want to check, if I did job with RF. Still a capture. Good. Stop. Now, I have to work on my contact, Here, PFA, please. Maybe I should target 20. Good, perfect. Yeah, and we are still in the same spot, you agree? So now, look what's happening with the contact. 14 grams, 9 grams, 11 grams, 25, 29. You see how it wobbles, during ablation. But you see stimulation. Now, yesterday we had this case, introductory review from the last year. And we saw that back at that time, there were already speculations that if you lose this stimulation during pulse field ablation, that it could be a good sign. Now, can we pace? Can we deliver it? There is a loss of capture. So how? So now stop. Because I'm not super satisfied with this contact during ablation, I'm going to repeat and stack another PFA here. We don't have too much of the data because when you have pulse field ablation configuration that has already a lot of trains in it, like 24 trains, then it's very likely that with additional application you get a little. When you have something that has only 3 or 4 or 5 trains, because no matter your power configuration or power, what is the power configuration of PFA, the repetition is a very important recipe of destroying tissue with pulse field ablation. So you see here during ablation, you see immediate I stop, it's 20 something. You see, it's a constant. I'm going to leave catheter here. I'm going to leave catheter here. It's a stable contact. During ablation, it's different. Is it sensor? No, because this afternoon when Daniel will show you a case with atrial ablation. Now try pacing here. Now I have a classic contact. Loss of capture. Good. Have a gray dot here, gray. So I put a gray dot. This is a dense scar. I don't want to visit this region again, okay? So now let's move from this region. Let's inspect maybe more of more. Okay, here do you see? See what happens? I'm in a process here. Good. Can you pace here now because we have electrogram scan? Okay, is this true? Stop. Is this true? Is this late potential? Is it true or mechanical? Okay, it's true. Sorry. Pace. Okay, again we have a capture here. So it's very area. So we have a capture. It's with 10, huh? Okay, so now let's just do PFA.
Wait.
Let's just do PFA because We have a high contact. I'm in some trabeculated part, Predrag spotted trabeculation there. I will just release it a bit, here, still high contact. I will release it a bit. And it doesn't look, okay, here. Okay, and now I just do PFA, okay? Can you pace again? Let's see if we can capture. So we are capturing, good. Stop, PFA. So now this happens, you see, I adjust, okay, here, let's see what happens with the contact. Now it's more stable, and we are still stimulating the heart. So one thing I would want to convey a message, when you're doing focal PFA in ventricle, things happen. And because of the stimulation of the heart, sometimes you're losing. So now we have very good ablation index here. I bet we're going to have a loss of capture here. Please, pace capture. Loss of capture. Okay, good. So this is what we do. Nothing special, you know. Now we have to really investigate the rest of the scar. Okay, let's go here. Now we are inside. Let's pace here. It's interesting. We are pacing catheter. It's very irritating. You know, when we start pacing, he gets a lot of extra beats here. So okay, the voltage here is. Look, when we compare what we had with Octrel and this, although with Octrel we are not. With Octrel we also picked up a PVC because. Can you do the protocol pace from RVD? Let's see. This potential is interesting. Let's see if we have some delay here.
Yeah, but the signals are definitely bad. You know.
We have. See, this is clear. No, this is clear, Predrag. This is clear. This is clear. Decremental conduction properties. So I'm going to ablate here. So let's work on a contact here. RF first, please. Let me improve the contact. Good. So this is good for RF, and later on I'm going to. Okay, we go RF 40 watts. If I would have a region below 10 grams of pressure, maybe I would go for 50 watts. But you know, as soon as we have 10, 15 grams, I think it's a big good contact. Let's see what happens with the electrogram. Good. So I think we are changing local electrogram. Good. So either 650 is my target. Usually, for some reason, there's no data, but in my practice, I really want to target 650. I'll improve contact.
They're also ready in the other lab, so if you want to go to check them.
Good. Okay,
okay,
stop here.
It will take
PFA,
a long time, I think, too.
Okay, but before PFA, can you pace? So now we're going to pace and see if the RF did a job, because good, RF did a job. Yeah. Let's do PFA. Now improve the contact. PFA. Good. Okay. So this is the way we do. We stack RF
doing this ablation, and we can move to another lab. Okay. Ante?
Absolutely, and we're gonna chime in again to show you, fortunately, non-disability. Goodbye for the moment.
Okay. Do we have connection with another lab?
See you later, and because we have work to do.
We can see you.
And then let's show the one of them, which is the deeping, very terminated with reversible. Yes. And then we will just substrate modify.
Tam echo na začátku, co jsme
dělali. Okay, we can see you, we can hear you. Can you introduce the patient again? What you did up to now?
Okay. Okay, hi everybody. I would like to bring you into your room, Professor Sarkozy and Professor Kautzner, and of course me. My name is Jana Hašková. I know that you knows me. Okay, we will do ablation of ischemic VT. It is scar related. We have a huge scar in the left ventricle. This is patient after myocardial infarction with coronary bypass, and he's 70 years old male. And we decided to perform this ablation on system Affera with the Sphere 9 catheter. And the patient has already in another hospital had already the ablation of ventricular tachycardia in 2018. But in 2024 he had some ATP from the ICD. But he refused radioablation, and now, due to VT recurrences and ATP and a shock, he agreed, and he's here on our table. We or maybe you can continue, Professor Sarkozy, with what we do and what is our workflow and our plan for this.
Yeah, thank you very much. We went transeptal and we started with actually first with ventricular stimulation. Now, unfortunately, we have like 3-4 morphologies. We will show you a few of them. We started with this VT1 morphology, which was a very slow VT. It's rather left bundle branch broke, and so we were not sure if this has anything to do with this huge lateral scar, which we will see in a second. Then we had VT2 with the cycle length was 150. This one was more right bundle branch, but this was coming from the lateral basal part somewhere from the scar. And we had VT3. These are all slow VTs. The clinical VT was a little bit faster. And so then one VT was switching to the other, so at the end we decided to just do a very good substrate map first to understand the dense scar regions and the late potentials, also based on the eyes. So that's what you see now on the Affera image. On the left side, we put the lower voltage limit down to 0.2. But unfortunately, there is except that basolateral part where you see a dense scar, we have the whole scar is full of late potentials. Maybe you can click on a few of those points to see how really it's during RV pacing we are doing this, and it was really everywhere we see late potentials basically. So then next, what we did, maybe Josef, you can explain on the eyes also.
We can maybe show the initial eyes. We went to left ventricle. Can we switch to eyes screen?
And it's a...
I don't, yeah. Can you show first few?
Yeah.
So this is from right ventricle. You see the big scar. You see big scar on the lateral aspect. There is a mitral valve. Can you move it? Yeah. This is catheter now below the papillary muscle. So you see the scar is really extending up to the level of base of papillary muscle. And if we can go to this left ventricle, this to the left, one more. Yeah. Okay, here. You can see. You can see now this is septum. You see some calcifications on the septum, but the main scar is actually it is lower septum up to the apex. But there is nothing interesting. But most of the scar is this lateral wall. It's a thinning of the wall, and it's from the valve up to the base of anterolateral papillary muscle. So this is exactly fitting this red area where we have on the map. So. We just went back from the left ventricle to the right ventricle because it's more instructive. You see scar much better from the right. If we can go now to real time, I can show you now. This is the scar. Andrea is with the catheter in an apical area of the scar. So up to here, up to this LAT is the scar visible on eyes, and it fits exactly this low voltage area on the map. And as I said, it is impossible to map during tachycardia because it's changing all the time, or interrupting, or sometimes it's faster, so there is low blood pressure. So we decided to modify this area from this side up to the base and see what happens. So the patient should have ablation in this area, but it doesn't look like anything has been done in here because there are late potentials everywhere.
But I just would like to show you one VT because we were trying to map this VT. Sometimes we saw mid-diastolic potential, which we tagged there on the apical part. But can you just please show that site where we saw that very nice deep and we paced and we initiated. So if you have now screen.
No, this is nice.
So if you see here, we do, for EVO, we do this S1, S2, S3 stimulation. And what you see after the spike, that's a deep potential. And then the next beat, you see again the prolongation and the induction of this VT. But what's even nicer, that with this VT, we were able to terminate, as you see there a few seconds later. We mapped a little bit around. It was we had a reasonable blood pressure, and then if you go to the termination on the mid-diastolic potential on the non-reversible
pulse here.
Here. So as you see here, can you please increase the gain? I mean the speed. Yeah. So you see there, we managed to get to this beautiful mid-diastolic potential area, and then in spite of Josef's skepticism, I persuaded him to give a reversible pulse there. And you see that without capture, because there is no QRS behind, we terminate the tachycardia. So we think this is specific for this type, this VT's isthmus. And now I think we will just start to modify the substrate. We have a lot of work to do. I think we will use PFA, no, Josef? Or what do you think?
I think well, we can do both. Well, we can use PFA because this is quite dense scar. I think we have a lot of potential, so it would be faster. And
so I don't know if you want to stay online or you come back to us after if there is, you have anything else to see. But this is, for example, the region where we take these late potentials. There seems to be it's a little bit of island of voltages of channels, and we have, you see on the ice how nicely we are in contact, so we will start around here to modify the substrate. But this is, look at the late potentials, I mean, it really looks
the
like...
termination site? This? Okay,
yeah.
Maybe you can start there.
Or maybe we can start there, okay. Well, we have so much work to do.
Yeah, it's more apical, septal, yes. Yeah, we are now. This is perfect now. Oh, we can go from here to the base.
PF, we use PF and we use double repetition as we discussed yesterday. So Josef is telling me I am good in contact, so we will just start here with the
echo, prosím, i jo, view.
PFA. We are aiming at, I think the temperature rise was not very high. We are aiming at, so the settings are no, probably it's, look, it's 1.5, the locus, the settings of PFA, degrees rise. It's
which setting?
It's 1.5 degrees rise, the setting on for the PFA, or is it 2 degrees? And what's the temperature of the patient? Okay, excellent. So we are using 2 degrees because I like kind of this more strict settings. Look at the potentials there. So we did some delay, but I still see some potential. So I will go a little bit farther out here in the direction of the scar and continue the modification. If there are any questions, please let us know why we are working here.
As we discussed repeatedly, I really regret that we can't do pace mapping in most of these sites because you can't capture. If we capture, there is very long delay, especially in this basal area close to the valve, but it's very unreliable to pace map with these small electrodes. So there is nice late potential here. You see very delayed, especially in D3. So yeah, we can go here.
So the contact is important, and we have bad contact. So we are seeing it on the ice. We are in some kind of contact, but not very good. But I also see it. We see it also on the temperature, and I like this impedance-based way of looking at the contact.
Yeah, but they are.
This is a little bit.
We are in contact, but they are trabeculations, so you never see like embedded in the tissue here, but it's in the contact, so I think it's okay.
Okay.
Andrea, in the previous case, Antani started with RF and then continued with PF in the same spot. Why do you decide? Can you explain why you decided only PF directly?
Because we wanted to show you pulse field ablation.
First and second, we don't believe in the RF-PF sequence. Actually, we don't believe in the PF-RF sequence for sure. In the RF-PF sequence, based on this, what we discussed, this very recent publication with the large footprint, we believe that with repetition, we have deeper penetration than with the first RF than PF, because there is less variance and somebody. Yeah, I know. That's but this is a redo ablation, so you would think, I mean, we have this kind of potentials in the whole scar. So having a redo ablation, look, they disappear now. Oh, no, there I still see them there late.
Oh, you moved.
I am just trying to move a little bit better to have a...
No, the contact is good, quite good.
This one was where I wanted to dip before, actually, but I don't know, may I dip or not?
You can dip. Yeah.
Let's dip. Because we tagged, we will treat all those sites, but we have a lot of work to do. But we were just curious. And we induced a VT. Yeah.
That's another.
It's maybe
type.
our
The blood
tachycardia.
pressure is 60, so maybe.
It's another type of tachycardia.
But it's maybe clinical from the interrogation because the cycle line is.
Okay, we do a limited lapping. Please prepare for.
Připravte si kardioverzi.
Yeah. Or overdrive pacing.
44.
We will start with overdrive, obviously. Wait.
This one was the one that we thought. It's getting earlier here on the apex, but are we going to overdrive this or?
Yeah.
Or cardiovert?
Overdrive. Overdrive.
It's not capturing. No, it's capturing. Okay, let's see. Termination.
Okay, můžete to vybít.
Okay, maybe we can look back at the signals. This was the morphology and the signals, please. The 12-lead ECG. Was that inferior axis and right bundle with V46? Yeah, so this we have seen this VT before, I think. So this was the one that we were searching in the bus.
Little variation again.
Because one is more negative QS than 3 is more
three
positive.
is more positive,
Yeah.
yes.
Yeah. Yeah, so I think it's, let's save this as VT5, but VT4, let's save this morphology definitely for the end, because this was, and the cycle length was 440, okay. So we will see this also at the end. And then we go back, and the initiation, can you show me if the initiation, was there a deep there or not?
Yeah, during deep, but I didn't see anything interesting.
Me neither. We need to go back and look. So I see the temperature I was suboptimal at this site, and we also still have late potentials.
Here you can switch.
Here we have late potentials.
And they are not disappearing because this is the fourth. Maybe we will do RF here. So we still, maybe now it's for the first time we do repetition.
I would give more.
They are very stubborn, these late potentials. So normally they should, at the end, we will use.
Remember that there is some calcification probably also in this. When we saw it on septum, so there might be also somewhere here. Also, it's not.
Look at this. I mean,
shining that much, but I can do RF as well.
You think I'm?
Yeah, it's sitting contra. Yeah, it is
look, I'm sitting on the.
Sitting contrabeculi.
Okay, now finally, and it comes back. Look at that. I thought it was gone, and then it came back.
Yep.
Now it can be also coming, of course, from the other side, around it, and maybe that's why we still have it. But we will just treat this whole region, I think. No, Josef?
Yeah, let's go to the base and slowly, and then we will see what happened.
Look at that.
Yeah, there's everywhere.
And it's excellent contact, as we see. You see on the ice the contact and the bubble formation, and it's a.
No, it's from the flow from irrigation. This is not bubble like heating, but.
So what if it still remains? So what we are going to do? I will go to the other side of Josef, to the other side of the because maybe it's breaking through somewhere from more apical or more basal.
Here we can do the whole thing here and then going back.
Okay, let's see.
We are still. We can go up to apical part, so it's about 2 centimeters more to this LAT area. Remember that we had these mid-diastolic potentials here, so it's all more apical exit. Exit is apical in all of these VTs.
So you can very nicely see on the eyes that we are in the scar region and that with good contact. If you see the image now, they don't see the image. Okay.
You can show them eyes.
Yeah, už jsme tam.
Okay. Now we are more. Yeah, this is towards the apex.
I try to move around. Here
everywhere.
we also have a good contact again.
Can you rotate the map to the right a little bit? So we have still this area.
Also, yeah.
We have to go there. This is a very lateral scar, actually, from apical area, from apicolateral to basal. Here, in this area, we had mid-diastolic potentials during one of these arrhythmias, which was mappable for a few
So here we have
minutes,
more potential, so maybe I will
Can
just
we pace from D2, for instance?
wait a second, because my contact is... okay, now I try
So it
to...
resembles one of these tachycardias, I think. It's not very long delay between stimulus and QRS, but we are on the margin of the scar now based on ice also. I would start here and connect to that area.
We are trying to stay in the abnormal voltage region, of course.
Yeah, but now you see it. It is really going from inferior
on the ice.
to...
Yeah, you see the ice image?
Yeah.
Yeah. I mean, we always try to somehow put into a relationship the voltage map and the pace mapping with this extent of scar visible on ice. Sometimes it's not so visible, especially in dilated cardiomyopathy, but in post-MI, you can most of the time very nicely identify the extent of scar and thickness of the wall, which helps to delineate the extent of the real substrate. So yeah, here we can go still. Still in
We have
scar
good
area.
contact here on
Yeah.
ice, I see. So these were two mid-diastolic potentials during one of the VTs, this region. I just looked at the potentials and I thought that there were still some, but I can go there.
No, I mean, like after making these lesions.
So we will just go ahead and do this further. I don't know if you want to stay with us or you come back for the end result, but we will modify this 3 or 4 regions, septal, lateral, apical, and where we had the reversible termination. And then we will remap, I guess. That's the plan, no? And we reinduce, of course. Are there any questions, or?
Are there any questions from the audience? Don't hesitate to ask. No, there are none.
Sometimes it's problem that you cannot induce, like yesterday, and sometimes you have too many. So that's a life.
Special present for me, I think, no?
Yeah.
Fortunately, the substrate is large. Fortunately, the basal part is probably kind of passive or silent because, as far as I see, all the VTs were more or less of apical exit.
Yeah,
The
but
one
there
from
might be quite
superior
long.
part was a little bit basal, but not very basal.
Yeah. You are right that most of the exits is going towards the apex, but there might be some. There is very, very long delay. So if we would do pace mapping like yesterday, we would see that there is a bad pace mapping with good pace mapping in the middle of this area, I think.
So here we had also a good pace map at VT2, and if you see the reversible was actually at the mid, you showed the reversible termination. That's where we did our first applications. But we will probably on the basal part, we will go inside the scar and kill the late potentials, no?
I think we should do a line up to the mitral annulus anyway, so it's, this would be the best to transect the whole substrate. Then obviously we will remap and we will reinduce and see what happened. You see the ejection fraction is not exciting, it's quite low. The patient is still stable, but he's on catecholamine, so we don't want to really do a lot of inductions and try to be on safe side.
What is the volume of LV? We can't see here.
It's
350.
350.
350. Okay. So if you agree, we will continue with the lecture via Zoom from Milan, and we'll be back in maybe 20 minutes for some conclusion or
That's perfect.
interim result.
Yeah, we will show you where. Yeah.
Yeah.
Thank you.
Thank you.
Good morning.
Okay.
Can you hear us?
We can see you. We can hear you. Good morning.
Very good. Good morning, Joseph. We are in the lab. We are ready to show the preliminary phase of the mapping and ablation procedure in a patient with Brugada syndrome. Close to me, there is the next generation of my lab, Giuseppe Ciconte. And can I have the information of the patient? Okay.
You have the slide there.
We have the slide. First slide, please. So this patient is 4 years old. Family history of sudden death. Took us in at sudden death at a young age. He had only syncope at the beginning. We did the diagnostic case, the diagnostic evaluation. Was inducible during the EP study ventricular fibrillation. Then we implanted the ICD. 1 month ago, this patient had cardiac arrest with appropriate shock. So we are ready to show the mapping.
Next slide.
Next slide. This is the EKG, is a very clear pattern type 1. Okay, go next. Next.
This is the Eichmann test.
This is the Eichmann test showing a very evident and very large pattern type 1. Next.
The shock.
This is the ventricular fibrillation documented from the SICD. So let's go to the lab to show what we did to prepare the representation of the substrate. This is the endocardial map. We use the endocardial map actually just as anatomical landmark to better reconstruct the epicardial aspect of the right ventricle. At the beginning, we did the map of right ventricle, left ventricle from the endocardium and the epicardium, but after several hundreds of patients and mapping, we decided to start immediately with the epicardial map. You see, this is the local activation time map, completely normal. Show the voltage. The voltage is completely normal, so we can go to the epicardial map. Giuseppe already did the pericardial puncture and reconstructed the anatomical shape of the pericardial cavity. You see the catheter is placed in the pericardial cavity. You are looking at the signal from this catheter. This catheter has a mapping area of 144 square millimeter. It has 6 parallel splines. Each spline is 2 French. We have 36 electrodes, and each electrode's length is 0.5 millimeter. This is a very interesting voltage map. You can see the purple area that is a very normal tissue, but we have also the green area. The green area corresponds to the epicardial fat. So the pericardial fat is not just a bystander area, it's part of the substrate. And very interestingly, in this moment, Giuseppe placed the catheter on the fat, and although we are on fat, we are recording fragmented activity in this region. So the fat does not mask the electrical activity because it is electrically transparent. And the fat will be part of the ablation target. Now the catheter is on normal tissue without fat, and also we record a very similar signal. So the fat just a little attenuate the real signal below. So you see the action potential is not very strong. We have short potentials, not very sharp, and the prolongation of the activity after the QRS. This is the typical baseline electrical activity on the epicardial map. Actually, the catheter is in the outflow tract. Giuseppe, can you go down to show how is the activity outside of Brugada substrate? You are on the Brugada substrate. Can you go on the left ventricle, Giuseppe, to show much better? This should be the electrical activity in the normal condition. The potential is very sharp, very narrow. This is the normal action potential on the epicardial aspect. Move again on the right ventricle, Giuseppe. So we confirm that the disease is localized on the right ventricle, epicardial aspect. In the outflow tract, we have the most fragmented activity. But the substrate of Brugada must be enhanced using the Eichmann. This is the reason why at the beginning of the procedure we do the Eichmann. But be careful during the administration of Eichmann, because you must use not 1 milligram per kilogram, because during general anesthesia, the effect of Eichmann is much more than when the patient is awake.
Start timer.
So, in summary, at the baseline, the bipolar map shows the normal right ventricle. Now this is the PDM map, the potential duration map. You see, the potential duration map shows that the fragmentation is specifically localized on the outflow tract. And this is what we can see at baseline. You see, we mostly are on the fat. This is very interesting. But you will see what's happened during the Eichmann. This green color became purple. The purple is the color we programmed on this software just to show the extension of the area. This software is custom-made. It's not available in the market. Unfortunately, Biosense never decided to provide this software for the other centers. You see, the Eichmann started. How much we did?
10 milligrams. We usually
did 10 milligrams.
Per minute.
Important is to see the correspondence between V1, V2, and the abnormal electrical activity in this region. You see the potential are starting to be larger and shorter. This is the demonstration that the sodium channel blocker is acting on the sodium channel of this region, impairing the normal function of sodium channel. If you look at the EKG, can you amplify the EKG, Alessandro? If you look at the EKG, is visible already the pattern type 1. Usually, during general anesthesia, at the beginning of the procedure, the pattern disappears. But when we start the Eichmann, the pattern reacts immediately, and the appearance of the pattern corresponds to the prolongation of the electrical activity over the QRS. Now the activity is very short, very fragmented, and very wide and prolonged. Can you show how you detect and measure the prolongation of the activity with the caliper? Let's show.
Okay, there you go. Now
we can start.
I think that
okay, you see the prolongation of the activity. This is not noisy. This is the prolongation of the potential duration map. Start to acquire the points. How much we did of Eichmann?
30 milligrams.
Only 30 milligrams. The ideal dose for this patient was 70, but was sufficient 30 milligrams. You see, the activity is very prolonged. Now Giuseppe is very stable to avoid noisy. Go down. Can you do a little more isomethylene, 10 milligrams more? Just
yeah, we have
the
a little...
potentials are very short.
Yeah.
This is not a normal action potential, so meaning that the sodium channel is not working. So very interestingly, how this bipolar map can be the surrogate of several hundreds action potential coming from each electrodes of the catheter. And we can see how the sodium channel is working, but also we can predict also the potassium and calcium channel. In this case, we look for the sodium channel action. You see after the QRS, you have a post-potential, so the sodium continue to enter into the channel, but in low quantity. And this low quantity generates very short action potential. So from the baseline island of abnormal substrate, Giuseppe is moving down to look if the substrate is more extended than we predicted from baseline mapping. Be stable, Giuseppe, be stable here. So the pattern now is very strong and the prolongation is unbelievable. See, be stable, Giuseppe. The potential are very, very short. So apparently, this is not, Giuseppe, this is noisy.
Is going posterior,
go more stable. So the catheter moved posterior. This can happen. So we go as soon as possible to the anterior aspect. This can happen in live, no problem. Giuseppe, go to anterior. Okay. Be stable here. Be stable here. Here. Be stable. Vai giù. Down. 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 Okay. Vai.
There you go.
See?
There you go.
See?
Here.
Going down, we have a prolongation. Can you show with the arrow the prolongation on the screen?
Look at this.
Michele, look here, how prolonged it is. Probably is more than 300 milliseconds. Can I have the number?
Show the measure.
The measure, see? You can see there in the upper window, you see? That is the very, very typical abnormal electrical activity and over prolongation of the action potential after the QRS.
From the
so
onset.
The sodium continued to enter into the channel, but in very low quantity, creating post-potentials. So this can be considered not just a mapping of electricity of the epicardial cavity, but the mapping of the channel function. You see here, oh, unbelievable. You see?
Yeah.
You see this double potential
late activity
and the late activity, very evident late activity. Be stable, Giuseppe. Avoid the noisy. Avoid the noise. This is stable, perfect. Okay. Okay, now go down because I think the substrate is very large substrate.
We do expect
that. Giuseppe, just to give an idea, how should be the potential, go to the left. Just to remember how should be the potential in the normal condition, see? Okay, go to the right now, go to the right. Okay. So now, be stable here. I expect the activity, the abnormal activity should be also here.
Well, here.
Fortunately, the activity of isomethylene is going down because usually last 3 to 5 minutes.
But still, we
try to complete the mapping within this range of the time. Be stable, be stable. Okay, okay. You see the potential very short and extremely fragmented, so the software automatically cannot detect also these very small activities. So the engineer is helping the software. Okay. Okay, stay here, stay here.
Here we have.
Here we are very close to the left ventricle. Can you go, Giuseppe, on the line dividing the right from the left ventricle? Sure. Be here. Here we have the interventricular artery. Here the tissue is normal, very nice. It's normal here. Not really. Here we have purple area. Michele, enlarge the area. In this region, we have purple area with late potential. Go down now. That is
we try to close
the pulmonary valve. Go down, Giuseppe. Go down. Don't lose time here. Here, okay. Giuseppe, can you go on the tricuspid valve? Because usually on the tricuspid valve, we can have more dense abnormal electrical activity. This is from the experience.
I think here.
Wait a moment. Now we have noisy. You are close to the right atrium.
Yeah, that's
You are
right
detecting the right atrium. Go down, Giuseppe. Go on the right ventricle. More on the right ventricle. Here, stay here. We are close to the tricuspid valve. We still have a very short action potential. Not very strong potential, but the substrate is becoming bigger and bigger with more detailed mapping. Here we have the most severe prolongation. Typically, the substrate in Brugada has an onion-like aspect, with the most severe part of the substrate is in the center of the substrate and the less severe in the periphery. The purple in the higher part is noisy. Michele, you can delete that part.
This is, I think, the most interesting part.
Yeah. See here, we have the most severe substrate in this region.
And the pattern
is most severe. And the pattern is going to be attenuated. See? So now we stop the mapping because every more point we acquire, we create a misleading mapping substrate. Now Giuseppe is exchanging the mapping catheter with the ablation catheter. The ablation catheter is a Q-dot catheter, the standard catheter we use for endocardial procedure. This is just an adapted catheter for the epicardial aspect. Unfortunately, we don't have technology specifically projected for the epicardium. But it works. Now, unfortunately, this part of the procedure cannot be defined at the beginning because it's strongly dependent on the dimension of the substrate. Each application duration is from 5 seconds to 8 to 10 seconds.
I would start.
Because you can start, Giuseppe, because the end point is not the transmural lesion.
Apply here.
We don't want to achieve the endocardium. It's just sufficient to create a very shallow lesion targeting just a fraction of millimeter of the pericardial aspect. Obviously, we are ablating what? We are ablating the normal tissue, the muscle. We are ablating the fat, and we are ablating altogether all the environment of the pericardial cavity. We are eliminating and ablating the lipids, we are ablating the proteins, we are ablating all the predisposition of these Brugada substrates. So it's not just the elimination of the electrical activity. And during the procedure, you will see that in some region, the EKG react, giving a more manifest pattern, because the increasing of the temperature in particular region can simulate the fever. And you know, the fever, and Brugada is a good company to show the severity of the disease. See, in this moment, the pattern is increasing in V1 and V2. This is due to the temperature increase in this region. But also, the end point is the elimination of the very superficial substrate in the epicardial cavity. Do you have a question?
Are there any questions to Carlo?
In the meantime, you can
so.
appreciate the V2 lead, the ST elevation is going up, and you see a flat and horizontal ST elevation, which is typically observed when we apply radiofrequency, and we tend to eliminate the phenotype expression of the disease. So this is exactly part of the endpoint of the procedure, that in turn will be the elimination of all abnormal electrical activity observed. I think you have a question. I don't hear you.
We don't hear the question. But you see Giuseppe is moving the catheter very slowly, especially at the border between right ventricle and left ventricle. Important, don't touch the coronary artery. Usually we do not perform the coronary angiography because, as you know, in this part of the heart is not represented any coronary artery. But we decide in this way after many cases, because unless we have anatomical abnormalities in the coronary artery, we never touch the coronary artery in this region of the outflow tract, anterior wall, or inferior part of the right ventricle. Here we are very close to the right atrium. Now we are between outflow tract and the anterior wall. You should expect in the next few minutes the horizontal aspect of V1 and V2 with the disappearance of the pattern type 1. Now the pattern is even more evident, although the effect of the Ashmalin disappeared.
Okay. Carlo, we must go back to IKEM in 2 laps for final remarks. So it's okay for you?
Yeah. Okay. No problem. It's
Thank you very much for the
case of the procedure. Okay, ciao.
We're going to take
Můžeme tady pacing, prosím.
Also,
yeah, let's pace here. Okay.
We're going live?
Okay, this is nice. Can we check can we match the morphologies?
Perfect. Hello, everybody.
Can you tell us what you did up to now?
Yes. So when we left, you, we started ablation in that portion of the anteroseptal, more apical to mid scar, and we surrounded the scar. Can you make the map more visible, but transparency, just to see the points? So we surrounded scar, transparency, stop there. So you see that from this aspect, we surrounded a scar and we did co-localize most of the lesions. If we had interesting spot in a scar, but with, let's say, 40 grams of pressure, we just did PFA. For the rest, you will see that every red has its own companion, 1 or 2, mostly 1, PFA lesions. We did have multiple applications at the sites where we had long stim to QRS, and we would loss of capture mostly after RF, but we did have one position where we had a 650 ablation index with RF. We could still pace capture, and then what we did is we did PFA, and there was a loss of capture. What Pruka, you see that we have multiple also aspects here with a long, with a delay. Can you do now? Look at this position now. Can you pace now this position? And after we did this, what you see on the table, we went for reduction, and the only thing initially, patient had a lot of VTs with the inferior exit. And now what we induced is the VT for with the more superior exit, with the inferior axis. And now we're gonna pace catheter here, pace catheter. And now we are probably nice stim to QRS. And this matches well one of the latest morphology we induced. However, let's do. So we already did RF here. So first, when I was talking, my catheter moved. Let's do RF here. RF, 40 watts. So now we're gonna do RF here. We're gonna test loss of capture. So now we are extending more from apical zone to more mid-anterior part. See on fluoro, we are doing some crazy maneuvers there. And now, after this lesion, let's go for induction. After this application, let's go for induction. We'd like to show you also that we ran there. Initially, essentially, had 4 different morphologies. Let's see. So now I'm going to stop at 650. Good. Try pace capture post-RF. Some capture beats. Stop. PFA. Ready? So about the catheter moved. Catheter moved, you see? So our last RF, last RF was here. Good. So now we are getting a PFA companion to RF lesion. And you see it again, it's continuously happening. See on EKG, we are stimulating the myocardium, and probably due to this fact, we are getting a wobbling and a contact. So now it's catheter is unstable. To be honest, this is one of the very few lesions where we saw this moment. You will see that most of our lesions is dark purple, which means that we achieved 550. So here I'm going to do one more. Can we pace? Still some capture. Good. Let me try to improve the contact here. Here. Good. Let me try to improve the contact by pulling out everything. Yes. PFA here. This is the zone. After this lesion, I believe we'll make it non-excitable. Now the contact again is wobbling, but I think we should get above 550. We will. And after this, Predrag, would you agree that we can go for induction?
Yeah.
Initially we induced with 2 extras.
I'm a little bit afraid because so far we have in total of 5 different morphologies of the VT and plus 1 non-sustained. So
I agree.
We can expect to induce.
But
something.
I like this pacing. So you know, but let's try induce. Let's try induce and let's focus on remaining substrate. Yeah, let's do. Last time.
Let's try to.
So
VT5 with 2.
VT5 we did 3 extras.
Yeah.
Repeat that. Scan that. So now we're going to do at the beginning with 2 extras. We had these 4 morphologies. Now we are at 3 extra. We are pacing RVD. We're not capturing.
Wait, I will improve the contact.
Good. So we are okay.
Go now.
Yeah, maybe.
Okay.
Okay. Some transient rhythm. Okay. And this is really basal. This is more like LVOT. You see. I mean, what you see now, it's
yeah, but
so
this
let's
is
go.
polymorphic. Let's go.
Let's go. Let's go induce. If you have any question from the audience, we are ready to receive it right
questions?
now. This is.
Sometimes we must go for final talk to the lab number 4. We probably.
So now these are 3 extras.
Leave you doing this
3 extras
testing.
Okay, so far so good. So we're only using a couple of unstable beats. Okay, so now can you induce? Let's do Michigan. Let's do 4.
So far so good.
4 extras. 4.
Okay, so we can leave you testing, and thank you for this case.
We are in. Good. Okay. You wanna? Okay. Sorry.
We connection to the lab 4.
Let's go.
V1, no? V1 is different.
V1 to some extent.
Well, we had it in
It's very
95%. It's,
Vidíme vás a slyšíme vás. We can hear you, see you.
Okay.
Can you say us what did you do in the
We are
meantime?
live? Okay.
We are, yeah.
So
we modified the scar. We did all those applications. We got rid of the late potentials in the middle. And then, but we are a little bit worried because on ice we see that the ejection fraction is going down, and during
you
applications.
See intracardiac echo.
Yeah, if
there
you
is
show
broadening of the QRS complex, and you see the function is not pretty good.
So then we decided to do after the remapping, we didn't see late potential, so we decided to do a stimulation, and we induced still a slow VT, which we are showing you on the Pruka, the morphology, which we thought, look at the QRS, how wider it became. And so we thought this was coming from the apex, so we went to that border zone on the apex, and Joseph did those yellow applications there. We had to terminate the tachycardia because we didn't have much blood pressure, and or we terminated spontaneously. But anyway, we did a few applications there on the yellow applications, the last one, and now we did re-stimulate, and with 3 extras we cannot induce, so we actually thought that it was time to stop. He is non-inducible with 1 cycle, 3 extras, and we are really worried about the hemodynamics.
Initially, we had spontaneous induction with movement of the catheters, so there was, every stimulation basically brought a different tachycardia. Now it's much more stable, and patient is really having a very low ejection fraction, so I think it's time to finish.
Also, in the SCAR, we don't see on
we
the
did
map.
pretty many applications of pulse field, although everything was in the dense SCAR, let's say, based on ice. It was all in this white area where you can see, but I think that's enough for today.
How many ablations
Put
did
it down
you
to
up to?
0.2 is the voltage limit.
Sorry?
How many ablations
applications?
is this?
73?
73,
How
okay.
many did we do applications?
Is there any question for this lab
79.
from the audience?
79 applications we did PFA.
Okay. So then there are no questions. So congratulations to the case. And thank you very much.
Thanks to Andrea. She was very patient with me, but I was also very patient with her.
At this age.
We are exactly in time for coffee break.
It's good, I think. Finally,
I think
it looked,
it's okay.